Hi, everyone. This is John Mandrola, and this is another session of the Sensible Medicine podcast. Today, we're really pleased to have Tracy Beth Hoeg and Vinay Prasad, of course. What would a podcast be without Vinay? So I think what we'll do is we'll just go through some introductions. And Tracy, why don't you go ahead and tell us about yourself?
All right. Thanks, John. Well, I'm so happy to be here. I'm a big fan of the 2 episodes of the show you guys have had so far, and I'm just excited to be part of this, and also the whole Sensible Medicine project. But so I currently live in California. I'm originally from Wisconsin. That's where I went to undergrad, studied French and English, and ended up doing some of my undergrad and living in France, and did medical school in the US in Wisconsin, and ended up eventually moving to Denmark, where I did a PhD in epidemiology and public health. I worked as a physician there, lived there for 7 years, became a citizen, moved back in 2015, did PM&R residency at UC Davis. And actually was just starting in private practice right when the pandemic started. And now I'm also, I'm in private practice. I work part-time at UCSF, actually with Vinay, in epidemiology and public health. And I have a couple other jobs, one in the Bay Area, actually a small company working on health policy. And so I've been busy, doing a combination of research and clinical medicine. So getting to use like both the MD and PhD, which is awesome. And happy to be in California. Absolutely love it here.
Great.
Yeah.
Vinay?
And we have to do you, John, because actually, this whole time we never heard your background. You just assume the audience knows. So I'll go quick. I'm Vinay Prasad. I'm originally from Indiana, and I did most of my training out in the Midwest, medical school in Chicago, residency at Northwestern, my fellowship at NIH. And then I was on the faculty in Oregon for about 5 years. I came out here about 3 years ago to be on the faculty at UCSF. I'm a hemonc doctor, and I do epidemiology, and I work in the Department of Epidemiology. And Tracy, we're lucky she gives us a few hours a week, but yeah, we work together on some projects, and hopefully you'll see them soon.
Great. Well, I mean, I grew up in Hartford, Connecticut, just north of Hartford. And when everybody was staying in Connecticut to do their training, I said, I want to go to the Midwest. I love the movie Hoosiers, and interviewed in all these Midwestern places, and played basketball on Friday night when I was interviewing in Indiana, and just, wanted to be a cardiologist. So I stayed in Indiana, trained in Indiana, met my wife, Stacy, and a job opened up here in Louisville, and I've been in private practice EP here for 27 years, and didn't even start doing anything writing wise for 14 years. And then I started a sort of blogging during the mommy blog era, and one thing led to another, and now I do some writing and podcasting and all that stuff. And yeah, that's how it all started. I wanted to, I'm so excited to talk to Tracy about this whole difference between the US and Denmark. And it really came due in the pandemic. So I'll tell a little story, my Denmark story. And I'm so hooked on Denmark. I went there in March of 2022, right as the Omicron thing was going on. And Denmark had just decided that they were done with restrictions. And so you go through the US airports, you go through Amsterdam, you land in Copenhagen, and it was like a time machine. It was like a time machine. There were masks, and all of a sudden you walk off the planeway to the airport in Copenhagen, and it looked like 2019. And so my friend picked me up, and we did a little bike tour of Copenhagen, and I said, "What's going on here? Do you guys not have COVID?" And he says, "Oh, we've got COVID, but the authorities had decided that it was under control, and that we were done living like that." And he said that in Denmark, this is what really stuck to me. He said, in Denmark, we trust our medical authorities and our government. And I said, wait a second, is that right? And so then, I started learning more, and I was there for a few days, and I was like, I asked other people, and indeed, they confirmed that the Danish people trust their medical leaders and their government. And this is such a foreign concept to an American. And so I just wanted to, do you think this was just not a random sample, Tracy, or do you think that this is sort of kind of a good sample?
No, I do think I think it's a good sample. And I also think that, the Danish public health authorities have given the people of Denmark a reason to trust them. And I think that as opposed to the American CDC, they do a much better job of sort of walking through the evidence and why they're making the decisions that they're making and what they're basing it on. I think probably my favorite example was Søren Brostrøm, who was the head of what's called the Sundhedsstyrelsen, which is the main, public health body there. It's the equivalent of the CDC there, when he kind of came out and said, looking back, we made a mistake about vaccinating children. We thought that if we did it, it would control the spread of COVID, but we were wrong, And so I think that they do a good job of sort of, admitting what they don't know, admitting when they made a mistake, and being transparent with people. And I also think there's a huge difference there where it doesn't, these issues don't become politicized like they did in the United States. And that has to do with, a country having multiple political parties, not just being divided between Democrat and Republican. I think it also has to do with the fact that they really encourage open debate in the media there. And so when you read the newspapers, it's they often feature articles by scientists who disagree. And I think we don't really have a lot of that in the US. And so I have such an advantage that whenever I'm in doubt about a topic, I can go to read the Danish news, and I can read the debate, and I can read their take on the evidence, because I know that their take is not going to be politicized. And so I don't know, I think from the beginning, I guess that's been my little secret of how do I figure out what's how to separate truth from fiction beyond just looking at the studies. It's it kind of helps me see through sort of what in the US has been, really pushed just based on political ideology.
It's quite shocking. The other thing that my colleague said was that he said on many of the big issues, the Danish people agree. And I thought, that's another thing. Now, maybe I think some of the naysayers in the US would say, well, look, Denmark's the size of Minnesota. It's a pretty uniform population. So maybe they have that advantage.
And I was going to say that is one of the issues with Denmark, is it's very, very homogeneous, and they do agree on many things. And, actually having been someone who came from outside of the country and the society to go live there, I sort of faced the difficulty of being a physician there. And I will actually say, because I didn't have a classic American accent for whatever reason, I was really, there was a lot of distrust towards me. And so I think in general in Denmark, there's this sort of sense of Danes, we have this way of doing things, we have our culture, and there is a distrust of sort of the, what's outside of it. And so, I think maybe a little bit to Denmark's detriment, they're not as diverse as, say, California is. That is actually a great thing about California. But yeah, that's part of it, is it's people sort of know that culturally they agree on things without asking each other.
But just one thing to add to this point, I think it's well taken that these are smaller nations, and Denmark is much smaller, akin to Minnesota. But if you look across all of Western Europe and Northern Europe, Sweden, Norway, Finland, Switzerland, Denmark, even to a lesser degree, France, Germany to a lesser degree. I think that the entire European response was more of moderation than the United States. And the United States, we're the most extreme. We have two really fundamentalist groups. either it, it doesn't exist and there's nothing to do about it, or, we should still be to this day living in our bunkers. I mean, those are our two extreme polars. The UK to a lesser extent. And so I guess I'm curious, yes, they're a small nation, but I don't know if that fully explains, why they so often find middle ground, because all the other nations sort of similarly did so in Western and Northern Europe.
Yeah, I mean, in terms of, I think the best example of that is the school closures, because I think throughout Europe, like they really agreed, like, and I think it has to do with their history of sort of a social safety net and the idea that really children need to be a safe place while their parents at work, and people need to be at work to make money. And so there was that whole, like, that all of Europe agreed on that. So that I think that the United States was really quite an outlier in our way of thinking about that. And it's really interesting how it ended up that way. But I do think it has to do with sort of the economic and social hierarchy in the US of people who are sort of making the rules or giving ideas about what we should be doing, not having to deal with the negative impacts of what they're suggesting. And I think that was definitely the case with school closures. And I think that Europeans are sort of the public health officials and the advisors there are a little bit less out of touch, and there's more of a sense of like, we're all in this, we really are all in this together. That wasn't here. Is like our sense of we're all in this together is everyone just needs to lock themselves away, except for the people that can't because they need to make money.
Deliver your food, except, I mean,
Right.
we all lock ourselves, except for the Uber Eats has to come and my Amazon Prime can't be late, but other than that, we'll lock down. Yeah.
Right.
Right. And of course, my nanny can't be late, or my, tutor for the children can't be late, these sorts of things.
Right,
Rich people had, but, average people didn't. But John, where are you taking this? Tell us what
One of the things that strikes me is that, I don't travel a ton, but the more I do travel to these other places, I wonder why. One of the things that I'm kind of frustrated about American, culture or whatever, is that we don't seem to incorporate or think about how other countries handle that. And when I was just running around Copenhagen and Roskilde, and right during the Omicron and I'm asking these questions, and I want to go back home, and I don't want to sound like the college kid who knows everything because I just finished college. But on the other hand, you see these other things, and you just wonder why. You wonder why authorities and people don't think about other ways to approach problems.
Well, and I think, a lot of people in the US were quite aware of what was going on in Europe and Scandinavia, but maybe they just didn't really want to make a fuss about it. And a lot of people just sort of go along with what they're told to do and what they should. And I think that's also something cultural here. And I think a lot of people sort of felt it was outside of their power to do anything, about it. I think we're going to get to the masks, but that might be going on with like, why all over healthcare are we still wearing masks everywhere, and why are we, I mean,
but I mean,
that's one example, but there's so many like that. Like, why can't people be with their loved ones, in the hospital now? I mean, it didn't make sense 2 years ago. It's like makes even less sense now.
And along those lines, I mean, so often Tracy or me or Marty or, somebody on social media says, why can't our vaccine policy be like X? And then, somebody fires back, oh, that's anti-vax. And it's like, actually, that's the stated policy of Sweden, or, that's the policy of Denmark. And to John's point, many people are just unaware that these are real substantive differences in policy around vaccines, schools, and we'll talk a little bit about masking children, certainly, masking to a lesser degree, but there are still substantial variation by country. Part of it is American exceptionalism means you don't need to look outside of America to know what to do. I think that's always been a bias of America. But maybe Tracy and myself, to some degree, one of the reasons why we might have thought differently about the pandemic from the get-go, she obviously has ties to Denmark, and I run a research team where, 25% of my team is in Europe. And so I'm constantly sort of influenced by what somebody from Switzerland thinks, or what somebody from, Portugal thinks, because they're on my team and I see them twice weekly Zoom meetings. So, I think it's important to know what other countries are doing and what, happens there.
Okay,
Yeah.
speaking of differences, I want to talk about two other things, differences between Denmark and the US. And the other thing that I was struck by when I was there is the difference in healthcare system. So I spent time in the hospitals and the EP labs there, and I learned that in Denmark, there's a public health. Get this. This was so amazing to me. And again, I don't want to sound like the naive kid from college, but I'm sitting there in the EP lab and I'm talking to the Danish docs about how the healthcare system is. And it's a public health system where everybody has healthcare. And you could say, oh, well, look what's happened to NHS. And, there's all this Canadian, you have to get in line to wait. And so, but the Danish people are even smarter than that, right? So they have this system where there's also a private system, which is very expensive. And if a patient is recommended for a procedure and they don't get it within 30 days or some amount, they can then go to the private system, and the public system that they're in has to pay for the very expensive private system. So when I was there, they were having some cancellations because of whatever, and they were struggling to get people on the schedule so that they didn't have any inefficiency in the system. So I thought to myself, this is like the best case scenario. They have a public health system where everybody gets health care and it's free, but then there's also an incentive to get people taken care of quickly. And I found this just amazing.
Yeah, I mean, no, that's true. I mean, there's the two types of healthcare that you can get, and there's this insurance 1 and insurance 2, and the second one is like the more expensive one where you can get access to more rapid care for like elective procedures and things like that. No, less than 1% of the population has that, and I think that actually speaks to what you're saying, that most people are actually quite satisfied with the basic healthcare there, and I didn't, working there, I didn't experience patients like waiting like an inappropriate amount of time for procedures or anything like that. Now, I was in ophthalmology, so it's a little bit different. But like, it was pretty rare that we would have a patient wait for cataract surgery for more than like a few months. So and like all of the urgent procedures like retinal detachment, like you do right away, like there weren't issues with like delayed care there, not that I saw.
So that's a clever thing that, I didn't know about, but it seems like they've solved one of the classic problems of single payer or single healthcare facilities, which is the lengthy delay and wait lists that plague NHS and plague to some degree Canada. And they've solved that in a nice way. But, I mean, all of Western Europe, I think, has different sort of solutions to tackle it. I didn't know about Denmark, so I think it's pretty clever. But I guess the point I want to make on this topic is that I actually agree that, I think healthcare is a fundamental obligation of the state in the same way education is and roads are and those sorts of things. You can call it a human right or, however you choose to call it. I think we have a societal sort of duty to each other for healthcare. But the part that gets me is I want it to be healthcare that actually works. I don't think you can tax people to pay for healthcare that doesn't actually help us and just enriches corporations, but that's a non-trivial percentage of what we're doing, And so the thing I most admire about European nations is that they're more conscientious about the cost effectiveness of what they do. But even they, I think, are not perfect. They could be running many more studies than they do. And they take a lot of things that from America and they just take for granted that they work. And I don't think that's true. But that's a really interesting observation, John. I never knew they did that.
So Vinay, this podcast is quite left-leaning then, right? Because everybody on this podcast believes we ought to have healthcare for all. I just want to make that point.
I think that's one of the challenges. I mean, to Tracy's point about politicization, to some degree, we don't all neatly fall in boxes. And my discontent with the progressive left COVID-19 position comes from the point of view of somebody who is on the progressive left for most positions, from regulatory science to taxation policy, to issues like abortion. I'm on the side of the progressive left, to issues like healthcare for all. But they got COVID wrong. And, if you really think about the principles of progressivism, one of the core principles is the children you should not abandon are the poor, vulnerable children. And yet everything we did, school closure, vaccine mandates, masking children, puts all of the burden on those poor, vulnerable children. So I think we've abdicated our principle because we, succumb to sort of partisan reactive politics and not using our brains. But your point's well taken. It's a very, we are this is a left of center discussion.
Well, the struggle, I guess the struggle that I have is, Andrew Foy put me on to the Constitution of Liberty. And so I've read Hayek and I've read a bunch of Hayek. And so I struggle between this true free market and actually this universal healthcare system. But I think at the core of it, the difference is in the universal healthcare system is somebody has to make a choice about what can be done. And I think this is the thing that really is a difficult barrier for America, because we just don't like the idea of some authority making choices, like, for instance, the nice system in Britain, but or the Canadian system. I don't know that there'll ever be a solution.
I guess your point's well taken, and my best solution for that is to say the public healthcare we offer everybody should pay for a floor of services that we really know work and deliver value. And then Tracy and John and we're free to get whatever private insurance we want in the private market. If we want to get, AFib ablation 4 times in our lives, if we want to chase things that may have marginal benefits, or chemotherapy at the end of life, so there's a private system for that. And then ultimately, nothing stops a person from using their own money to pay for whatever they want, from going to the movies to going to Barbados to healthcare. I mean, nothing stops you from using your own money that way. I think, and this is the part that I probably agree with Foy and you on, which is that to me, it's an unspeakable thing to tax middle-class people to pay for healthcare that doesn't work. I mean, I think that's just non-starter. But that's what we're doing in the US. I mean, we are doing that. And even some degree, they're doing that in Europe. They're just maybe doing it less.
Yeah. And I mean, if it's left wing, I guess, to say that we want to have universal health care, but then is it it's also left wing here to say, I want to have a COVID testing program in my school. And so then, do I have to agree with that? I guess, I have to say, since living in a multi-party country, and I've really struggled with the idea of personally identifying with a political party. I think that the issues are just too complex. I mean, and it gets to what Vinay is saying, that you can say that you want to cover everyone, in terms of healthcare and their basic needs, but then you also have to say you can't endlessly cover everything. And I feel like in the US, we've gotten into that problem now where always doing more is the liberal side in healthcare and health policy, and how is always spending more is not going to end up, getting you where you want to go. And so that's just the issue with saying that there are only two sides.
But that's a great example, Tracy. I mean, absolutely well taken. The great example you're giving is somebody on the progressive left in America, in addition to saying universal health care, is also going to say we need universal free testing every day at schools.
Yes.
And then the difference, I think, between universal thiazide prescription and universal testing every day in schools is universal thiazides for people with high blood pressure has rock solid evidence that we improve outcomes at a very favorable price. So, society could invest in that and it will be good for everybody, the person and society. But testing every day in schools has, as you know, god awful evidence to support it as a strategy. And in fact, if they ever tested it properly, I would bet all the money I have that you'll find is you'll halt school tremendously. You'll disrupt education massively. And at 1.5 years later, you'll have the exact same seroprevalence as if you didn't do it. And so it's a useless strategy, particularly useless when you use antigen testing that's negative when you are able to spread the virus, because it has the false negative early on. So, I mean, to your point, Tracy, I think to me, politics and principles of politics is what is the outcome you care about, the well-being of the population, and are you willing to marshal taxation to do it? That's what progressivism means. But it's an empirical question of whether or not things work or not. That should be left to technocrats who can sort of think about that. But the problem is many people put on their progressive hat and they can't use their evidence-based medicine hat. Their brain is broken for that. It's just broken.
Okay. One more thing before we get to the Cochrane. I want another striking thing that I learned, Tracy, was that when I was there in a research program, I learned that to become a cardiologist in Denmark, you had to earn a PhD before you could go into practice. So you went to Denmark and got a PhD. And what I noticed from going, listening to the presentations there, a lot of young people giving their presentations, is number one, there's a tremendous amount of research coming, at least in the cardiology space, from Denmark. And number two, as like, it seems like people get out of training quite late in their life, age 40 or so. But the other thing is that there was a tremendous amount of social support for families, and people got home on time, and there was enough child support. And it was such a striking difference between what, like, my daughter struggles with her childcare here in the US. And I just wondered if you could comment on that.
I mean, yeah. So I can just comment on what the medical education is like there. I mean, just to give people an idea, so you go to the equivalent of high school, which includes 1 year of college. And then at the end of that, you decide you want to apply to go to medical school. And it's really difficult to get in, just like it is in the US. And then you go to medical school, which lasts 6 years. So it's a little bit longer than here, but it includes, undergrad training, but it's free. So I think that's important for people to take note of. And then you apply to do your basic internship 1 year. And then you can do intro stilling. It's intro position. And basically that's the one thing I'm going to say is when I moved back to the US, I had forgotten all my English, but okay. So it's come back now, but so when you do the intro and you basically try out different specialties, there's no rush. That's just the thing about training in Denmark, was that people spend many years to figure out what it is exactly they want to do. And there's not that same sort of I need to get done so I can start making money. Because, the medical school is free. You don't have this huge debt, and you're making money and you're doing fine. So you can just kind of explore the different specialties. But what you're saying about cardiology and needing a PhD. So there are different specialties, just like here, that are more competitive to get into. I actually didn't know cardiology was one of those. Apparently it is. But ophthalmology was similar. You don't absolutely need to have a PhD, but it kind of depends on your qualifications. But most people, at least in ophthalmology, sounds like cardiology, some other specialties, will need to get one, especially if you want a position in a desired location, like in Copenhagen. And then that training takes 6 years. And the work week there is about 37 hours a week. I mean, I would say in medical training, a lot of people will work a little bit more. It's not a lot more, but you also have a lot more paid holidays, paid time off, paid maternity leave, supplemented childcare, even late hours into the night. So when we were on call, we could get childcare actually later hours that, and it's very, very family friendly. And so you get very easily spoiled, as you can hear, but that's the basic structure of it. But you don't make a ton. I mean, it's not like you make a huge amount of money. And I should point out too that when I did my PhD, I was paid, but I had to apply. I had to get a grant for my own salary, and that's a different discussion. But everything is paid, and it's people are, even in their medical training, you're living very comfortably enough, so you're not rushing to be done so that you can actually finally start making money.
One of the things I noticed on that point was that it was 70-30 female to male. And so one wonders whether if we wanted more, if we wanted more women in cardiology, maybe providing the kind of support that they do in Denmark would be one way to get that.
Yeah, I mean, I definitely think there's something to that. I mean, I will say that in Denmark, it's over 90% of moms work full time. So I think that really tells you everything that you need to know, because that was a huge actually culture shock for me when we moved back, having never been a mom in the US when we moved to California. And it was all of the moms of my kids' friends were stay-at-home moms. And it was so strange to me to think so you get all of this education, and now you don't get to use it, but you're like, women are put into this position where like you have no other choice in so many circumstances. Like you have to prioritize your kids, like they're doing the right thing, and yet it's like our society, the way the US is set up, it's like that's their only choice.
So I'm totally with you both on the thesis that if you provide more support for people, particularly parents, et cetera, you'll be able to have a stronger labor force and better participation of women in the labor force, et cetera. And, we could learn some things from Northern Europe. The only thing that I'll quibble with you, John, about is that if we made all our trainees do a PhD, they still wouldn't know anything about interpreting studies.
Well, that might be true in Denmark too. I don't know.
Okay, well, anyway, let's get to the meat. Let's get to the meat. The reason I came.
All right. Let's talk about the Cochrane review on non-pharmaceutical measures to stop the spread of respiratory viruses. And so, Vinay, why don't you give the rundown? And I think we want to really hit. I really want to hit the idea of this whole absence of evidence is not evidence of absence, and I want to hit the idea of looking at evidence in regards to what our prior beliefs are. So children are Bayesian learners, and they have prior beliefs, and then they see new evidence and they update their prior beliefs. And I think this is really relevant to interpreting this Cochrane review. And I also I really want to point out what actually is a Cochrane review and what is a meta-analysis, and what's the difference between a Cochrane meta-analysis and some of these other kinds of off-the-cuff meta-analysis that you see every day.
All right, so it's a lot. I'll try to summarize briefly these points. So what makes Cochrane unique? Cochrane is a well-established and historical collaboration of people who are very interested in evidence-based medicine, who seek to provide impartial, objective assessments of the literature. Cochrane does some things that other people don't, like exquisite pre-registration, lots of internal checks, including peer review before they publish their reports. And I think historically has had a high level of credibility, but a Cochrane report is very good. Now, I should put a little asterisk, a few years ago, 10 years ago, there's a big brouhaha between the Cochrane CEO, Mark Wilson, and Peter Gocha about levels of evidence. And there's some debate in the organization. And then there's another asterisk around, there's a particular report about statins that everyone's up in arms about. But both those caveats aside, Cochrane does good work. This report is done by Tom Jefferson. He's based in Rome. He's a very seasoned evidence-based medicine reviewer. He's recently interviewed, I think, on a Substack post that I was reading this morning, where he says, I don't tweet, I don't talk on social media. I'm just a scientist. And that's how he views himself. He's famous for the Tamiflu reanalysis, when Roche had to turn over primary clinical study reports from the Tamiflu randomized controlled trials. Tom Jefferson went through each report with his team. Like, we're talking about hundreds of thousands of pages by hand. They recoded all the adverse events and all the outcomes, and that led to that very famous BMJ paper on Tamiflu. So he's a good reviewer, and he's done really rock solid work. This is the second, in the last 4 years, this is the second update of the Cochrane review. Came out this year. They had a report come out in 2020, and it's like physical interventions to slow the spread of respiratory viruses. So it's anything from hand washing to wearing eyeglasses was in there. At La Frette Times papers in there, to masking, which is the hot button topic. And the outcome is anything for influenza or, COVID-19 now, wasn't there in 2020 because there were no studies back then. And he's looking primarily at randomized controlled trials. And the too long didn't read of the report is that if you look at randomized controlled trials of community mask use, he concludes that the point estimate is basically null. There's no evidence that it will actually slow the spread of respiratory viruses, both in individual and cluster randomized trials. He also looks at N95 versus surgical masks among healthcare workers, and he also finds that that's a null signal as well. And so when you look at the highest level of evidence, the randomized trials, not the Maricopa County versus Pima County observational study, even though one county voted for Biden and one voted for Trump, and one county has higher vaccination rates, that kind of confounded stuff, you get, certain effect size. You look at randomized data, the effect size vanishes. Now, the last thing I'll just say, many people, we have to acknowledge, we live in a world where many people are fervently pro-mask. And those people are arguing something that is, it's technically true, that just because this report shows that these randomized trials failed to establish a benefit of masking, it doesn't mean that masking doesn't work under any and all circumstances. Maybe the right mask, the right recommendation, the right person, it would have worked. And they call this the absence of evidence is not evidence of absence. In other words, just because you don't have evidence that it works doesn't mean it doesn't work. It's not evidence it doesn't work. And it's technically true, but to your point about Bayesian reasoning, that's why I think it's practically false and practically incorrect. And the reason is, the way I always view it is, in the last 100 years, there have been probably 10 million or 100 million different ideas that very smart people like John Mandrola or very smart people have offered that will improve upon our condition, from flecken-eyed post-MI to routine use of Swan-Ganz catheter to, if you have dust mite allergy, put your bed sheets in impermeable bed covers. I mean, there's thousands of hypotheses that make perfect sense. Of all the things people have suggested, the vast majority don't work. I mean, in drug development, for every 100 drugs in Pfizer's pipeline, they're lucky if 4 will come to the US market. And so the odds that something you're not doing actually offers a benefit are really lottery-like odds. And so practically, I think what this means is the absence of evidence is evidence of absence, because the pretest probability most things work is really, really low.
So Tracy, you've done some studies on masks, and I mean, what do you say to people who argue, well, if you just wore the mask all the time, or if you wore it appropriately, it would work under these circumstances?
Yeah, I mean, I don't think that, we have good evidence that that's even the case. I mean, I agree with Vinay that it's like, it's very, very difficult scientifically to ever say that if you do something exactly perfectly, that it's not, especially with masks, that it's for sure not going to work. But I think that the issue comes first, like with recommending that people do something, and then the next level is with mandating that people do something. And so I think that when we've now have all these randomized studies in multiple different situations with with N95s, with cloth masks, with surgical masks, and we're not detecting any evidence of benefit in terms of preventing the spread of respiratory viruses from them. And so, I think with the evidence that we have, it's like, we definitely shouldn't be mandating that people do it. And like even recommending it comes with problems, because then people feel like the obligation to do it, or they feel like they need to tell other people to do it. And I guess you could say it's just masks, but, especially, we don't want to exaggerate the issues, but it's like, when you're imposing it on children, I mean, and it can impair their learning and their communication with each other. I mean, yeah, that's the issue. And so, I think that with the studies that I've been doing, I mean, the most recent one is, I think, a really good example of what actually of medical evidence and the type of evidence that's been used to promote the masking, because Amber Chandra and I reanalyzed one of the CDC studies that they published, the Budson et al. Study that was used as rationale to recommend and mandate even masking in schools. And they use such a short study period time and such a small group of people that they end up finding a significant benefit. And it might actually just have to be with adjusting their numbers with the social vulnerability index that they got, the numbers that they did. But basically, when we reanalyzed their data with a larger sample size in a longer time period, the effect disappeared. The MMWR and the CDC refused to publish our reanalysis. And then we eventually got it published in the Journal of Infection. But you can see the problem here with that, not everything is getting published if it's negative, because people are afraid of the implications of publishing something, that they think might have a societal detriment. And so journals are erring on the side of not publishing, studies that find negative impacts of masking. And so actually everyone should read that Marianne Damasi interview with Tom Jefferson, because he talks about how their publication was delayed for 7 months during a very critical time. It was from April to November of 2020 that the publication of their original Cochrane review was delayed. And so, I think that we have seen more of that than we know, and not during the pandemic, and not just with masks. I mean, I guess we were involved in a study together, John, where we faced similar issues.
Yeah, I can't imagine that there would ever be. I mean, it's just shocking to me that there would be a delay and pressure in publishing certain kinds of data. I've never heard of that. Never.
And then one more point to Tracy's point, which is that, what Tracy also found is that based on the time interval you look at, you can either get a favorable benefit if you cherry pick the right time slice, or if you look more broadly, it's negative. This kind of analytical flexibility is everywhere in observational research. And so for a question where people are very invested, like, does it make sense to mask Massachusetts school children? And you run a analysis that's even published in a prestigious journal like New England Journal, there can be many analytical choices you made along the way that yields the result. And so I always like to say that it's tough to do an observational study objectively when you already have written a change.org petition. As in this case, you already have the change.org.
Yes.
No, but I mean, that's such a huge point, this whole analytic flexibility. I mean, maybe we need to get Brian Nosek on and talk about how you look at data can change things. But I want to ask you one thing, because one of our projects at Sensible Medicine is to explain critical appraisal. And one of the things I want to ask you, either Tracy or Vinay, is, okay, so when Tom Jefferson puts these trials together, he finds a null point estimate. But on the left and the right of that are these 95% confidence intervals, and they allow for benefit and they allow for harm, and how do you parse this? A point estimate is null, but what if there's wide confidence intervals, and does that give credence to folks who might say that the intervention you're studying, it's just, we don't have enough information?
Let me take a quick crack, and then I'm curious how Tracy will answer. My best crack at this answer is that—
Pretend it's not even a mask, just pretend it's anything.
No, right, any intervention. Somebody pointed out that, when you run failed superiority trials, you fail to demonstrate superiority, you often have a wide confidence interval. To tighten that interval, you're gonna have to crank up the sample size tremendously. And then somebody said on the internet, there are some people out there who will not let go of this particular hypothesis or any hypothesis until your confidence interval is so tight, you prove net harm, okay? Which is a very high threshold, right? And you have hundreds of thousands of people and you run it to net harm. Maybe we got there with hydroxychloroquine actually, but for most things, we don't get to there. What I wanna say is, in the history of medicine, most of the things we do not do today that you teach the resident, like once upon a time, we used to give heart failure patients isoproterenol, or once upon a time, we didn't give, whatever. Once upon a time, we used to do autologous stem cell transplant for breast cancer. Those things we used to do that we don't do anymore. Most of those things that have been debunked, discredited, have not been debunked to that threshold that you're talking about, that you've proven with a very tight confidence interval that it's like net decremental. So we don't use that as the burden to throw something out. The burden is, if you can't prove it works in some reasonable period of time, we're done with you, okay? We're done, especially if there could be harms. So that's my best answer, why, even though that confidence interval goes from 0.74 to 1.4 off the top of my head, I still think it's pretty neutral or negative results. But I'm curious how Tracy will answer.
Yeah, no, I mean, I was just going to get to the exact same point of the burden of proof, that it's up to the investigators and the people who are trying to say that this intervention works to show that it does. And even if, there's like wide confidence intervals, I mean, they haven't shown that it worked. And so, yeah, you need a better study to prove it. And I don't have too much more to add to that. I mean, there are so many examples. I was just thinking of in your book, actually, Vinay, Ending Medical Reversal, about PSA is another great example of that, right? Like, yeah. I don't know, there's so many examples, but it's interesting how we it's also children's vaccines, like the data that I would say, every time I think of wide confidence intervals, I think of the infant toddler vaccine data, and we never got good randomized data on that, but
for COVID-19.
For COVID-19, yeah, sorry, the COVID-19
for 6 months through 4 years old, that data is terrible. It was, yeah.
It's kind of actually unreal.
How terrible.
that it was, I mean, and I think that's why, most countries never actually gave the infant toddler vaccine because the data was never there. So,
And to be fair, most Americans didn't give it either to their infants and
yeah,
toddlers.
that's right. That's exactly right. It was recommended, but we didn't know.
Right. And that I just, we got to close, but it just also gets to the thing we started talking about in the beginning with just trust in authorities. And, if regular people can see that there's no data, and or regular people can see that, if you're masking my 3-year-old, and when I go pick him up, he's, hanging out at nap time without his mask in the same room. I mean, regular people are just going to say, well, wait a second, if they're recommending this, what are they really thinking? And so I just, I think one of the biggest problems with recommending things like that are just, difficulties with trust.
Yeah. And it's become like a moral thing too, right? I mean, masks, it's become synonymous with caring. And I think that's why we just can't shake it. It's like, it's always, it's just the sign that you care if you wear a mask. And I mean, I don't know how things are there where you live, John, but here in California, it's like still just so many young people wearing masks, and I can tell it's because they want people to think like, I care about you. And it's like, I appreciate that sentiment, but it's also like, well, we don't have any evidence that it's working. So,
whenever I point out that there's some young person wearing a mask, and I'm like, why are they wearing? I saw somebody wearing an N95 outside in the rain, and the rain is pelleting it. And somebody's like, well, you don't know that they didn't just have a transplant and they're about, they just want to take it off between. And I was like, yeah, but you don't know that all those people who took ivermectin didn't have helminth infections, but we can guess that that's probably not why they're taking that ivermectin, So yeah, I mean, the reality is they're doing it because the youth is liberal, and the liberal position is, Donald didn't do it, so we got to do it 10 times as hard because it's good people do. And just one last point with the moralizing. I mean, I think Tracy's right. The moralizing is a problem. I have a post in my Substack where I said something like, I am personally not going to get any more boosters until you prove to me that, a 40-year-old guy in good health who already got 3 doses and already had COVID derives a benefit from that extra dose. I'm not going to do it. And Todd Lee, the, professor in McGill University, he said the same. And, an MD, PhD student said the same. There's a few of us who say the same. And I think it's a pretty reasonable position. I don't want to keep taking medical products in perpetuity, and then somebody is trying to argue, and they don't argue the facts. They don't actually say, Vinay Prasad is wrong and he should do it without randomized evidence. Here's why. It's all just, a smear campaign. One of your essays on your Substack was once reprinted by a journal that caters to a conservative audience, which is true. Why did I allow them to reprint my essay for, no amount of money? Because what do I want? Fewer people to read my essay? I want more people to read my essay, of course. So anyone wants to reprint my essays, I'll say, reprint my essay. What do I care? Tracy once had coffee with Joe Ladapo, who's a Surgeon General of Florida, who met Ron DeSantis. Yeah, okay. But he's a nice guy. He's a professor. He's an MD, PhD from Harvard. They're friends. Doesn't mean anything about the merits of the argument. And this is fundamentally ad hominem. Now, why do people paint with the ad hominem brush? It's easier to paint with the ad hominem brush than actually sit down and try to think about the data. It's a lot harder to sit down and think. Anyway, we're going over too long, but.
Yeah, well, this has been a great conversation. It is over what we planned, but it's so good that I think it's great. And Tracy, thank you so much for coming on, and we're going to have you again. And it's really great. And so we'll see you next week, everybody.